All right, great. Well, I really appreciate coming back also for the third time, like Dr. Galgano. This is such a great meeting, and I'm always learning things, and it's my favorite topic. So this year, I got the same title as last year. So since 2024 was the title I was given. So I didn't know if maybe I was supposed to talk about the past or the future or maybe something else entirely. So we'll see. It's going to be a little bit different this year, though, than I gave the last 2 years. So hopefully a little bit of something for everyone. All right, so I have no disclosures. But let me just say, so for the people in the audience who haven't seen this before, for me, this has kind of been the talk that kind of made my career a little bit right out of fellowship when I went to my first academic job. Um, I started out, I wanted to kind of get to know the clinicians. I talked to my boss. I said, how can I really get established? It's hard for a new person right out of fellowship. Everybody else in my group had been there forever. And he said, take over a tumor board. And he said, I have the perfect one for you because it's a good one. He said, spine oncology. And I think he really gave me that one because it was super busy. It took a lot of preparation and it was very early in the morning, but I did it. And I realized very quickly, that if I wanted to be taken seriously in that group of all the surgeons, the spine surgeons, radiation oncologists, I didn't know everything, or thought I didn't know everything. So I started reading everything I could in their literature about, kind of the things we were talking about. And I ended up making a lecture about this because none of the radiologists in my group or anywhere at that time knew about this. And even in the spine oncology tumor boards, we weren't talking about SINS and the epidural spinal cord compression scale yet. So when I gave this lecture, this was always the way I start. So anybody who's seen this has seen this case before. So this was a 56-year-old woman who came into a busy county ER in the middle of the night. All she said was back pain. She was that some of the populations in that area, they're people who don't necessarily get good medical care. They don't want to share their histories. They don't want to say much of anything. So we didn't know anything about this patient. And so my fellow said, should I call down there? Should I get more information? The back pain. I said, no, we already know what this patient has. We got our sagittal T1. We got complete infiltration of this L1 vertebral body and a pathologic fracture. Probably some other areas of low T1 tumor infiltration here. Here we have our sagittal T2, and I'm explaining these for the people in the audience who might just be learning some of the imaging. We have our sagittal T2 to kind of see what it's doing to the thecal sac, a little bit of compression of the conus. We've got our sagittal STIR, or fat-saturated T2, which really highlights edema. Again, kind of showing off at least this metastasis, probably these as well. And then our fat-saturated post-contrast image. So it's fat-saturated. T1 hyperintense fat is all taken out, so everything bright is actually enhancing tumor, a little bit less than we would have thought there. But here on the axis, you can indeed see that there's infiltration of the body, epidural extension of tumor. So when I gave this in my talk to people, this was kind of the big thing. I said, and I did this from what I had read about the SIN score and the epidural spinal cord compression scale. And I said, which report impression is more useful here? The one that my fellow wrote that kind of describes things. It's okay. He had like 2 pages of other stuff that he was describing, and then this impression. Suspected metastasis, pathologic fracture of L1, retropulsion produces moderate compression of the conus, blah, blah. So it's fine. But mine was unstable spine. SIN score 13, recommend prompt spine surgery consultation. And then number 2, lytic metastasis L1, fracture with retropulsion greater than 50%, involvement of bilateral posterior elements, all components of the SIN score. And then as number 3, I put high-grade conus compression, ESCC goes grade 2. So that's, what I told the radiologists about this was, these things, when the ER doctor calls up to the floor and says, neurosurgeon, we need a consultation for this patient. When they hear or read this impression, they know exactly what they're going to get when they get down there. So they don't even have to see the images if they don't, or if they can't pull them up. So they're ready and they know what they need to do. Or more importantly, even, when this goes down to ER and they see, cancer, they might not even call spine surgery. So in the middle of the night, I want this person who is going to escape, when she leaves the ER, we might never see her again. I want her to get the care she needs and be seen by the people she needs to be seen by. So I gave this to my people. I was fortunate to be able to give a big talk to a very large group of radiologists, and it really resonated with them because for the first time, radiologists saw that they could make a difference for patients. We're always told, the surgeons, nobody reads our reports, just put whatever, describe whatever. But for once they saw that, they saw why they were doing it and how this could help. So this was really, a game changer and became very popular. And kind of, I had my colorful pictures I made, and I showed examples of all the different aspects of the SIN score, like the location. Here we have, kind of demonstrating the difference, cervical junctional regions, how it's more, gets a higher score because, there's basically nothing holding the head. On the spine, on the sagittal angiogram of this person with renal cell carcinoma, higher score, 3 for this one. Whereas in the sacrum, even though you have a huge melanoma met, T1 hypointense on this axial T1 MRI, it's on the bone, on the axial CT image, you can see it's eroding through the bone into the neuroforamen, causing a lot of pain and might fracture, but it's not going to cause instability, so that gets a 0. So anyway, I went through all these things for the radiologist. And again, it was kind of easy for them to understand. They said, oh yeah, we can do that. And I kind of explained how the SIN score worked. Again, I made my little drawings, pretty amateurish, but that's all I could do. And then, my epidural spinal cord compression scale. And again, I've gone through this in the past, but I think now everybody kind of talks about it. So I don't want to be redundant. And you can also read about it. And I think now, 10 years later, everybody knows it. So, which is amazing to me, but kind of giving the justification for doing it. But then the other step that I took for this was I made a template for them for their reports. So they didn't have to memorize it. So in radiology, even neuroradiologists, we don't just do spine, we do brain, we do head and neck, we do nerves, we do all the modalities. But, especially trainees, they do every part of the body and every modality. So there's so much that we have to remember that if you can make it easy for them, then they'll actually maybe do it. So this structured report and then these common data elements that we created from this for research and machine learning, building this was kind of the big difference. And that again was kind of what started my career in all this. So the big thing for us, which I think might be important for you as well, is we want to standardize our language so we're all speaking the same language content. So again, we want to be reporting what you need to know, the treatment team, because we're part of the team, we're not the treatment team. So it's much more important what you need to know than what we want to say. And then again, this is another part of standardization that I've been working on since then, common data elements and macros. So having that structured element in the reports will allow us to have things like annotation of images for machine learning. It allows for automatic notification of providers of critical results. These are all things we're working on now. They're incredibly difficult. Registries and billing and all these things. So this again, I told my people in the room, I said, how would you describe this? This is an axial MRI T1 from a person with renal cell carcinoma. How would you describe this in your report? How would the person next to you describe it? How would the person across town describe it? And everybody's going to describe it differently. Cord compression, anastomosis, all this stuff. And again, I think this topic, spine oncology, was such a perfect one to illustrate the need for us to standardize our language and improve our reports for treatment purposes, for categorization, evidence-based medicine, research, machine learning, and everything. So I won't go too much more into that right now, but I think this is something that I believe in surgery this is done as well. I know that that it's a little bit different situation, use more data than imaging, because the imaging is really the hard part. But all of this stuff, this is now how it's going now for me. This is now what we're working on, is automated reporting of critical results. And so this is coming soon, but again, it's incredibly difficult to do this. So people who think machine learning and things like that are coming soon, it's really tough. And if you're working on that, you know that. This is another thing, though, that's come up for me more recently, and I want to relate it to spine oncology. And this was my talk at the American Society of Spine Radiology meeting last month. And I asked the audience, if we were reimbursed primarily based on patient outcomes rather than volume, would you do anything differently? And your answer to this, if you think, I told them to think about it, and it really resonated with people because we are so driven now by volume. We can't help it. We've got 200 studies a day. That's all we can think about is getting through the stat. For you, it's a little bit different, and especially for you in this room, because you all really, in oncology especially, all you care about is patient outcomes, or primarily. Maybe people in the community, surgeons, oncologists, they don't have quite as much time to just care. I mean, everybody should, but there are other factors at work that maybe you still need to do the volume. But anyway, thinking about these issues, I think is very important for all of us. For radiology, we're kind of stuck here where we're trying to make better images. We're like, oh yes, we'll make something clearer. We want to, or maybe even be able to, diagnose something a little bit better. But that's really at the bottom of this high value of care pyramid. We want to be up here. So when we're doing like degenerative spine, 99% of our MRIs are useless because, not only, is the spine different in the supine position than standing, but really, we're nobody is really having a life-changing outcome from our MRIs for DGen. Oncology, though, we have a chance to make a difference. So, and that's a good example where we can make a difference. We want to be doing studies that actually change, make changes, morbidity, mortality, increased benefit for these patients or all patients. So this is what we would really like to focus on. So I was trying to think, how can we do this in spine oncology? So this picture, I like this because it's people on this faculty are in this picture, and this was at the Spine Summit a couple of years ago. I gave this SINS talk. I was asked to give that, and at the end, our friend Dan Shuba very nicely asked me, if you give a score for this, is that going to, is there any liability for me if I don't act on that, or any problems with that? I said, well, you tell me. That's why I'm here. We're all learning from each other. And then I realized, I'm using SINS in a very different way than a lot of the surgeons and radiation oncologists. Why do you all use it? Treatment planning and multidisciplinary planning. And I think I just told you the reason, or the way I use it. These people coming in the ER, we may never see again. I need to get them to the right person before they go out and have a pathologic fracture, pain, paralysis, and death. So for me, I think it's, again, I've introduced this to a lot of people, and I've sold it that way. So it's a little bit different, but I still think it's very valuable to get people to you to get the treatment they need. So again, I was trying to think of this kind of in general, how can radiology increase their value? And I think it's super important to have conferences like this. So everybody talking, me learning from you, anything I can add of value, that you might learn from me. This is what we need to take better care of patients, is working together, because we're so siloed. And even though this conference, even over the last few years, I've seen, things have changed, we're still siloed, but we're getting better. We're getting closer, I think. So communication, I don't know if Matt Goodwin is still in the audience. I know he was here a little bit earlier, but at my spine meeting, or the spine meeting before mine a couple of years ago, he stood up in front of the whole audience of radiologists, and he said, why do you report level by level and make my patients go crazy? So the next year I said, please, Matt, come back next year to my meeting. And I invited 6 surgeons to come tell us, what do you want us to report? How do you want us to approach these things? Dr. Galgano has always been there. He's always come to help us out. John Shin, so a lot of the people, I think this is how we're going to improve outcomes from the radiology side. And you all inviting me and some of the other, spine surgery meetings, inviting me to come talk to you all, I really appreciate it. I hope I can add some value too for better care of our patients. This is again about reports, because Dr. Chapman asked about that last year, but I'm not going to go into that because I don't have enough time today. Collaboration, we need to do that. So this was, I'm really fortunate to get involved now. I get asked by some of the surgery societies, to help with these white papers and recommendations and things like that. So with frailty, with vertebral bone collide, we've done 2 of those right now. We've kind of decided, the thing I can add as a radiologist is say, you can say all the things, your outcomes in your research with the vertebral bone collide score, but I can tell you, what's wrong with that in terms of physics. So does that really work? Is that the best tool to be using? Because you can't standardize, between a 1.5 and a 3 Tesla magnet, and you can't even standardize between magnets, GE, Philips, Siemens. So really you might have outcomes based on, some of these VBQ scores, but if you're using different magnets, which you are, does that difference really, change things for you then if it's not quite right? It probably still is fine, but, it might be that CT and opportunistic screening is the way to go. And we kind of had a discussion about that. Things that come out, I hope I'm not picking anybody in this audience who might have written about this, but like this M-plate score, this doesn't work, by the way. There are papers about this and the outcomes, but it doesn't work. So having a radiologist on board and, to know some aspects, we all have our specialties, and having that I think is super useful. So this, I think, is kind of the future. And this kind of goes in also to what Dr. Galgano was saying, the opportunistic screening. This is part for bone mineral density. This has been a lot of years of painstaking work trying to get normative values. And now we're trying to get it for the other factors, the other things in the body composition as well, like the sub-Q fat and the deep fat and the aortic calcium. We need to get normative values. We need to, make sure age and gender and all these other things are accounted for to make sure this is accurate. Now I've got AI tools for this, and it's taken forever. These actually kind of work, but there's still a lot of work to be done. Again, I think this is kind of the promising thing, and Dr. Galgano, talked about this a little bit, but we know that when we put, there are a lot of good papers about when we put some of these things together, the sub-Q fat, visceral fat, aortic calcium, bone mineral density, the ratios that we can create from that really have prognostic value, it appears. So this is for metastatic disease. These people, how long they lived after their diagnosis really correlated with some of these different distributions and ratios. So again, I want to kind of go a little bit faster because I want to show you a couple cases. I started my timer late, so will you let me know when I've got like 5 minutes left so I can go. I don't want to go over because I know there's a lot of good stuff left. So do I have 5 minutes left now? Is that?
I was saying you're doing great. Go ahead.
Oh, okay. You tell me though. Tell me. So education, that's the last one. So how can we improve it? Through understanding of surgical assessment and treatment. This is what I'm telling my people. And this is exactly what so many things Dr. Mendel said at the very beginning. It really resonated with me because he said, don't approach these patients as a surgeon, approach them as an oncologist. Well, I'm not a surgeon or an oncologist, but I am doing my best. I'm the closest thing that my people have right now. So I tried to teach them. This was a talk I've given a couple of times where they're, the different causes of spinal failure. And I try to go through and I tell them, for tumor, these are the considerations. These are the goals of treatment, which I've learned kind of from the literature. Again, I don't pretend to know how to treat them like you all, but I'm trying to give them an idea. And then this is what we can do. We can use the SIN score. This is why we're using the SIN score. And then we can also, after they learn that, we can also brainstorm and say, well, what else can we be measuring? How else can we measure this that maybe that people haven't thought of that will get them these metrics that they need? So should we be reporting, the volume of tumor in every vertebral body? If there's posterior cortex breach, what is the bone quality, whether by CT or MR? So we're starting to talk about these things as well. And I think, kind of, again, knowing what you all need will help us know what to provide and how we can help if it hasn't already been thought of. Osteoporosis, same thing. Kind of talking about how the goals of care are different. And could we prevent this if we actually use the tools that now are becoming available? So again, this is the opportunistic screening for osteoporosis. And I'm mentioning this because Dr. Chapman mentioned at the end last year. So whether they have cancer or not, this is a super important socioeconomic, social, population issue. And this is something probably that has developed the most in radiology. It's even, gone through, I think, cleared by it's something with CMS, and now people can actually get this. I don't know quite how it's paid for yet. There are huge problems with this. This algorithm doesn't grab a doctor by the hand and say your patient has osteoporosis, you're taking care of them now. I think Dr. Mendel also said, or Dr. Chapman said, maybe who owns these patients, who takes care of the patients, and that might not be exactly what you meant. But the problem with these kind of things is that when we find things, when this algorithm running in the background on all these body CTs that nobody's really looking at, but goes into the chart, when it finds stuff, when it finds osteoporosis, hopefully somebody's going to take care of that. Who's liable if they don't? Or if it finds a tumor, who's going to take care of that? And who's going to be liable if nobody even notices it in the background of the EMR data? So a lot of problems or a lot of big issues coming out of that too, but this is, I think, kind of the future. This will be something I think we're seeing soon, all of us. So I show this slide too. So multidisciplinary conferences is the last great way. I think we can all learn from each other. I show this picture because this was from my this conference. I think either last year or the year before. So I was trying to show you all these fancy new tools. I thought, oh, I'm going to show you. You're going to be so impressed with my bone MRI and my perfusion and my diffusion and all this stuff, radiomics. But at the end, all the questions were about radiology reports, osteoporosis. I gave the same or similar talk. And some other neurosurgery meetings, this is Chris saying, just his only question was, why won't radiologists help us? So I think all the advances in the world are great, but communication and getting closer and working together is the best thing. Okay, so now you, again, tell me when my time's up, so I want to show you a couple of cases. And again, this is kind of, you know how to treat them when they're found, but what about before they get to you? So this was a 70-year-old with frequent falls, hypertension. Keep coming into the ER for all these falls, and she kept getting sent home. They thought she had a PE, so they got this CTA. They didn't find a PE, so they sent her home. She came back again. Abdomen distension, nothing in her abdomen, so they sent her home. You all can see this, and you know probably where this is going because it's spinal oncology talk. But you see this little thing back here. This was actually me looking back in this chart from a patient that came in very recently. So she finally got an MRI. Because all these CTs kept being read as negative, and you can see the problem here. So we've got an intradural extramedullary tumor, T1 hypointense. This is our sagittal STIRS, fat saturated T2. So it's kind of bright on that, indenting the cord signal abnormality. I shouldn't say indenting, it's compressing the cord. So we call it they hadn't even gotten contrast. We said, if you want to get contrast, you can. I already know what it is, but you can get contrast. And they did. So I think that's generally we don't have path yet. That's what I'm guessing. I was looking back in her chart before because I thought that's not something that just appeared, and she's had all these falls. So she had come in before for this pneumonia. But again, in that same study, that calcification was there. That mass was there 6 months ago. Same thing here. And you can see very subtle. So this is something that I think, I don't know how we can fix this problem. So this was passed over. And we, you all were talking about who should be taking care of these patients in terms of really specialists at high volume centers versus who gets all comers. So I would say this is a pitch for neuroradiology, because this is passed over again by body. We shouldn't expect them to know, body radiologists to know about spine tumors. If it was a neuroradiologist, I hope they would see that tumor right there and get them to you before they're already, having spinal cord damage. This is another one real quick. So it reminded me, all my cases are like Dr. Rendell's cases too. He said those were kind of unconventional, but I think they're very conventional. These are the ones I see every day. So this was a guy that came in very recently, 72-year-old with low back pain, lower extremity weakness, no history of anything, no cancer. He was moving his couch a couple of days ago. He had back pain after that. It really rapidly got worse. So this is his CT. So pretty good alignment. They were about to send him home in the ER. We had 100 strokes. And so we were reading our strokes, and I think they were impatient because they needed to keep the ER going. And they were about to discharge this guy. And we're like, hold on a second. Is there something wrong with this L1 vertebral body? It's got areas of patchy sclerosis. There's something else in this. I'm not going to say it yet. And of course, on this, you can see there's a problem with this pedicle. Apparently, the nursery resident went down, after we said, take a look at this guy. And he said, oh, he had a remote history of an L1-2 discectomy or something. Well, I don't see evidence of that. I don't think that's his problem today. So they actually sent him for body CT. I don't know what was going on down there. But this, again, is maybe the value of radiology. You guys all know exactly what you're looking at for spine tumors. But do you know this? So what is wrong in these pictures right here? In this body CT, you can see the biggest problem for this person. We know what's going on. So we have our sagittal. Again, there's that patchy sclerosis. And I bet you can see, you guys are good. But abnormal soft tissue here in front of L1-2. Very ill-defined, patchy. And I don't expect you guys to know this, but over here, there's something that shouldn't be there. And it's a big pancreatic mass. So again, coming out of the body, there's abnormal soft tissue. We skip ahead quickly. This was something I taught my fellow that he didn't really know. So you can actually see something hyperdense right here. When we're going down, we're looking at neural foramen. There's no foraminal fat there. And actually on this, you go back, there's no epidural dark fat here. This is maybe for the trainees who are watching this. Look for your epidural fat that's really should be dark. It's not here, and it should be. This is the level above, this is the level below. So there you can see there should be fat around there. There should be fat, never this big blob of soft tissue there. So we don't know what that is yet because it's so new. But this was the MR, and they finally got it. I asked them to make a rush on it because I knew it was something bad, but I thought maybe for diagnosis, it would tell us what it is. So you can see, sorry, Dr. Galgano, this is another Bilski grade 3, I think, but we don't get grade 2s either, except that one I showed you in my example. But so I'm kind of guessing what it is by the other masses in the body and the distinct other, lymphadenopathy, but I'm not going to say for sure because I don't have path proof. I don't think it's what Dr. Mandel had. But it could be though. We'll see. And here's the tumor filling the neural foramen. Like we saw in the sagittal, again, we can see where the tumor is by looking at our path accessible education. And there you can see it actually on the CT. So I would again pitch for neuroradiology adds value, but this kind of education, seeing a lot of these cases adds value. I think it's easy when you see it well. It's harder when it's subtle like these cases, but a lot of these patients, boy, I feel sorry for them because out in the wild getting no help. And I don't know what we can do about that, but we're all doing our best. So, and that was another one. Should I do one more? Do you want one more or no? I don't want to hold everybody up.
I mean, we are coming up to time, but what do
You
you
want the last one? You know what it is?
run
Should
through?
we voice the audience here?
Go ahead. Go
This
ahead.
one was a good one. This one got sent home from the ER too. But
This-
you all know what it is.
This is our life, so I'm not surprised to hear you having the exact same thing happen.
Well, yeah. So that's so expansile, little calcification, sent home. The person had a tumor section thought that was like dural calcification. They came back pain the next day. MRI, sagittal T1. This is not what a normal T1 should look like. You can't see much of anything. Sagittal, fat saturated T2, stir. Again, where are the nerve roots? We know something's abnormal here. Finally convinced them to get contrast. I don't know why all the ones who need it are the only ones that don't get it. All the people who don't need it do get it. This huge thing, it actually wasn't even called right when it came through. I got called by the surgeon to overread this. It's called infection because it was all over the spine, all the way up to the cervical spine. Abnormal enhancement. This is a sagittal post-contrast, fat saturated. Everything bright is enhancement. So I said, no, this is not infection for sure. Builds the canal, it remodels the canal. Biggest epidendymoma anybody ever seen. Okay, I'm gonna stop there. I have one more case, but I won't show it, even though it's probably the best. So anyway, that's what I wanted to show you. I didn't want to show you the same old sin score again this year. I wanted to show you some cases so we can all learn from each other. Kind of tell you what I think is important, which I think, again, Dr. Mandela's, what he said in all those cases really resonated with me. And same with, Galgano and I have been working together forever and, really wanting to improve the outcomes for patient and work together closely. So thank you again for having me. Anybody want to see these cases later? We'll show you later.
Well, thank you for the great talk.
Sure thing.
Just quick.
Dr. Shelvin.
I really appreciate that that CT scan. Going through. We talked about the last time you were with us the importance of screening for osteoporosis, and if anything, I do think possibly with our whether it's just a regular abdominal CT, that may be even more accurate than the gold standard of a DEXA scan, because we do see some very poor bone quality, even though the DEXA scans are read as normal. And so I do think that that's something that's going to be, changing pretty quickly here in the years to come. I know Dr. Chapman had a question. I want to let him.
And even if the DEXAs were read right, only 6 to 13% of people that should be getting screened are. So I don't even, if it's right, they're not getting it. So yes, we can be writing that in the background. Fantastic.
Dr. Gibbs, fantastic to see you back again. Glad you updated at 25. It's 26, 27, 28, 29, 30 to come. Always great to see your perspectives and so enriching. All flattery aside, you showed cases which are so easily missed. 2 questions. Number one, why are we not doing more sagittal MRI screens of the entire neural axis like that epidendymoma case? This is so relevant for us to see anything from brain down to sacrum. And imaging time is what costs so much. Axial images swallow so much time and imaging proficiencies or resources. So why not more sagittal screens for these at-risk patients like infections, tumors, et cetera?
There are a lot of answers to that. I think one, again, I don't want to diss anybody. I'm trying to think of how to say it quickly, but a lot of times the way these come to us, they don't even know what they're looking for. 99% of our cases are going to be normal, although we have 100 abnormal ones too. All these cases, like everybody showed, are super common for us. But I think we don't do the screens because we don't know who yet to do them on. And it's going so fast. We have a super busy ER. And if maybe it was a little bit more controlled environment and there was clinical decision support or something, that might be better. But the way these are, they're just sending them to scan before they even examine them. So that's one problem with it. I agree with you. That'd be super helpful. But the other thing is, because there's so many scans now, I just showed you some nice ones, but our image quality is getting worse because we have MRs in the ER and they have really short protocols. And so you only get like 4 slices through the sagittal. So you might miss it even though it's there. So I agree again, that would be a perfect thing if we redo all our protocols and if it was a little bit different environment. I'm voting RCTs are so good. I think RCTs can see everything. So I would vote for more screening CTs with just somebody who knows how to read them. And then if we see anything, then we get the MRI for sure. So that'd be my approach to that problem. But again, it's all training. And Dr. Galgano said, he feels like he knows more now. He's done this for 7 years with a lot of complex cases. I feel it's the same with training in radiology. If you've seen a lot of them, it's easier. But unfortunately, there's so many scans these days, you don't have people who've seen a lot of them doing it or specialized. So.
Image overload's a reality. I'm on call, and literally our ER doctors in the 43 ERs here order pan MRIs on everybody. So it's literally just like whatever they come with, they don't want to miss anything. So MRI C-spine, MRI T-spine, MRI L-spine, and then chest out and pelvis CT for good measure. segue question, whilst we have the benefit of having you, Dr. Gibbs, and Dr. Bilski together. Score overload. So we talked about image overload, now score overload. And I'm sure that Dr. Bilski would address that in his lecture on chordoma, but what scores really matter? And I've asked that before, Dr. Gibbs, how do we propagate the essential ones that they're part of every single EMR that deals with oncologic patients? Thank you both for your answers.
Well, yeah, from my side, you know, when I started this, people on the radiologist side didn't know it because we're so siloed, not because it wasn't, you know, super important, but just people didn't know or didn't care, and they're in their own little world. So for me, it was a way of explaining to them, you know, why them saying something different in every single case, everybody saying something different mattered. Like we have to say the same thing. So use this score, which is simple. It's easy to remember. Even if you just say low grade versus high grade, that's better than nothing, but say it the same way. And so again, I think that really got adopted, not just because of me, but because, you know, they finally became aware of it. And so I think that is a great one, because that's easy to remember and it's important, and it's easy to explain why it's important. You think it's important, Dr. Bilski?
Yeah. The ESCC score, I think, is important because it gives you a sense of the acuity of the issue. And so reporting it out on a standard MR read gives the providers, you know, if that MR comes to the person who ordered it, the med onc, and they see a grade 3, it's an automatic referral to neurosurgery as an emergency. Whether it is or not, it's a different story, but at least they have a sense of it. So maybe 7 or 8 years ago, we started, you know, uniformly reporting that on the standard MR reports, and it's been a godsend for the institution to know what's acute and what needs to be referred right away. So I think it's a useful score in that sense. It
And
also standardizes the reporting because, you know, some people will call something high grade and some people will call it, you know, not, or vice versa. Or ESCC 1C is a high grade. For some people, anything in the epidural space is high grade, and at least it gives you a sense of truly what's high grade versus not. So I think it's a useful score in that sense.
This might be just one last comment on this, and I want to take your time, but it might be useful for you all in the future. So as we're working on automated notification of providers from the actual images, it's almost like not even going through a radiologist, which I think don't tell, but I think sometimes it's okay. It's going to be, our first use case is actually going to be Alzheimer's disease, ARIA, that bleeds in the brain from the new Alzheimer's drugs. But the next one, actually, we almost started with this, the SINS and the ESCC Bilski score, because it was kind of a very clear-cut case. But that's going to be our next one. So as we work on that, all the technical issues, you know, someday that might go directly, you know, that information from the images into the EMR and out to whoever ordered it. So it's I think it's super valuable for that reason as well. It's, of all the things we can do in radiology, which are a million things, that one is so clear cut and it's such a good system that it's going to be an easy one to show the value of for the machine learning and some of those automated information technology things that are coming. So watch for that.
Wendy, how much, this is Udi Mendel, how much conversation is going on between you as a diagnostic radiologist and the interventionalist when it comes to biopsies that is I mean, do you guys separating yourself, or you guys kind of kumbaya together saying, hey, this looks like cancer, there's no cancer diagnosis, let's get the interventionalist involved? Is there
a radiology intervention or somebody else?
Radiology, like let's
that's me too. I'm both. So
yeah.
So I think, I've learned more recently too. I was surprised when people, like I heard some stuff from Dr. Galganos, from other people saying these services aren't available everywhere, which really surprised me because I guess I've been in academic places where we were trying to make ourselves available, but I know that's not everywhere now. And I understand what a big problem that is, whether it's for biopsy or whether it's like C1-2 injections, things like that, you know, I'll do anytime because I like to work with my surgeons. I like to help these patients. But maybe a different way to answer your question also would be that, because it was mentioned before, like I always used to work with my surgeons exactly where I was going to go. I'd tell them they thought it was a chordoma or sarcoma or something. I said, okay, do you want me to go here? Or we should go there. So we always had like those kind of conversations. I know that's not possible everywhere, even to get the biopsy, let alone to talk as a team. But I think that's super valuable as well. And so I don't know what the answer to that is either. If people, radiologists, I guess, are so busy reading images that we don't have time to do procedures anymore. But I think it's super important to be in contact about all those things.